infection, vaginosis, trichomonas, vaginitis, vulvovaginal candidiasis, inflammatory vaginitis, senile vaginitis. Bacterial vaginosis, alteration of normal vaginal bacterial flora, loss of hydrogen peroxide producing lactobacilli, overgrowth of predominantly anaerobic bacteria greater than 1% of the flora of normal women with BV concentration of anaerobes, as well as Gardnerella vaginalis and Mycoplasma hominis 100,000 times higher than in normal women, lactobacilli greater than absent. Not known what triggers the disturbance of normal vaginal flora. Postulate, greater than alkalinization of the vagina, frequent sexual intercourse, use of douches. The normal vagina, normal vaginal secretions from spacious, sweat, bathholin, and skin glands transudate from the vaginal wall, exfoliated vaginal and cervical cell, cervical mucus, endometrial and oviductal fluids, microorganisms and their metabolic products increase in the middle of the menstrual cycle, increase amount of cervical mucus except oral contraceptives, vaginal disquamative tissue responsive to varying amounts of estrogen and progesterone, superficial cell, reproductive age, estrogen stimulation, intermediate cell, luteal phase, progesterone stimulation, perobasal cell, postmenopausal women, absence of hormone. Normal vaginal flora, 6 different species of bacteria, predominantly aerobic, hydrogen peroxide producing lactobacilli MC, survival of bacteria, vaginal pH lower than 4.5, availability of glucose, glycogen, monosaccharide, lactic acid, gram stain, normal superficial epithelial cell, gram-positive rods, lactobacilli. Sequele, BV with significant sequelae, increased risk of pelvic inflammatory disease, postabortal PID, postoperative cuff infections after hysterectomy, abnormal cervical cytology. Pregnant women with BV, risk for premature rupture of the membranes, preterm labor and delivery, corium neonitis, post-caesarean endometritis. Diagnosis: 1. Fishy vagina loader. 2. Gray vaginal secretions and thinly coat the vaginal wall. 3. Higher than 4.5, usually 4.7 to 5.7. 4. Glue cell greater than, increased advanced cases 20%. Leukocytes greater than, absent 5. Fisherman-like odor less than, Co. Treatment, drug of choice, metronidazole, excellent activity against anaerobes, poor against lactobacilli. Avoid using alcohol during treatment and for 24 hours thereafter. 500 mg twice a day for 7 days, 95%. Single, 2 gram oral dose, 84%. Clindamycin 300 mg twice daily for 7 days. Metronidazole gel 0.75%. 5 grams twice for 5 days. Clindamycin cream 2%, 5 grams twice for 7 days. Side effects: mild to moderate gastrointestinal upset and unpleasant taste. Clucell, A: Clucell, A: Trichomonas vaginitis, STD, high transmission rate, 70% of males after a single exposure. Anaerobes greater than ability to generate hydrogen plus O2 accompanies bacterial vaginosis 60%. Diagnosis: profuse, purulent, malodorous vaginal discharge with vulvopruritus. Vaginal secretions may exude patch, vaginal erythema and strawberry cervix. The pH of the vaginal secretions greater than 5.0, motile trichomonads and increased numbers of leukocytes. Clucell may be present if test positive. Sequele, postoperative cuff cellulitis, prom and preterm delivery. Treatment: metronidazole, drug of choice, single dose 2 grams orally and 500 mg twice daily for 7 days, 95%. Sexual partner should also be treated. Metronidazole gel, not effective, not respond greater than repeat multidose regimen, greater than single 2 gram dose once daily for 3-5 days. Strawberry, A: Trichomonad. Word: trichomonas, A: Tricho, A: Trichomonas, A. Vulvovaginal candidiasis. 75% of women experience at least one. Candida albicans 85 to 90%, Candida glabrata and Candida tropicalis. Dimorphic fungi blastospores. Transmission, Asymptomatic colonization, mycelia, colonization, tissue invasion. Antibiotic use, pregnancy, diabetes. Symptoms: homogeneous thick discharge, cottage cheese, vaginal soreness, dyspareunia, vulva burning and irritation, external dysuria, erythema and edema of the labia and vulva, skin, discrete pustulo-papular peripheral lesion, pH normal. Treatment: flunazole single 150 mg 1% hydrocortisone adjunctive treatment. Fungal culture: Candida A, Candida vulvovaginitis, Candida A:\T, wet Candida, chronic VVC, persistent irritative symptoms, burning less than itching, direct microscopy of the vaginal secretion and fungal culture. Chronic dermatitis or atrophic dermatitis. Flunazole 200 mg/day until symptoms resolve. Prophylactic doses: flunazole 150 mg/week for 6 months. Inflammatory vaginitis, diffuse exudative vaginitis, epithelial cell exfoliation, profuse purulent vaginal discharge, cause unknown, relative absence of lactobacilli, replacement with gram-positive cocci, usually Streptococcus sx, purulent vaginal discharge, vulvovaginal burning or irritation and dyspareunia, P/E vulvar erythema, vulvovaginal ecchymotic spots, and colpitis macularis, pH greater than 4.52%, clindamycin cream 5 grams once daily for 7 days. Atrophic vaginitis, menopause, surgical removal of the ovaries, sex, develop inflammatory vaginitis, increase purulent vaginal discharge, dyspareunia, postcoital bleeding, atrophy of the external genitalia, loss of the vaginal rugae, friable vaginal mucosa, TX, tropical estrogen cream for 1-2 weeks, systemic estrogen replacement therapy to prevent recurrence, senile vaginitis,